Hello, everyone. Welcome to our training today. My name is Jenny Reiner, and I am a project manager for the Choices Project at the Harvard T.H. Chan School of Public Health. And we're excited to have so many of you join for today's training session on how the Choices framework can advance chronic disease prevention and address health equity. Today's session will be led by Dr. Stephen Resch and Dr. Michael Long, who are both co-investigators with the Choices projects and experts in this field. So before I turn it over to them, since we have so many new faces who have joined today's session, I'd like to share a bit more about our Choices Community of Practice, which is hosting today's event. First, I'd like to acknowledge our funding that makes this work possible. Our work is supported by the JPB Foundation and the Centers for Disease Control and Prevention. The Choices Community of Practice is one of our newest collaborative opportunities offered through the Choices Project. So the Choices Community of Practice includes people whose work focuses on advancing obesity prevention, healthy eating, and active living, and want to learn more about how cost-effectiveness analysis can advance our efforts and address health equity. Our goal is to support these efforts by providing tools, resources, and training opportunities. We'll be sharing the link to the Choices Community of Practice portal in the chat, where you can learn more about the community of practice and register to join as a member to have access to these resources and opportunities. At the end of today's session, we'll be highlighting a few upcoming events that we welcome you all to join and participate in. So now I will introduce our facilitators who are leading today's session. We're excited to have Dr. Stephen Resch join, who is a lecturer in the Department of Health Policy and Management at the Harvard T.H. Chan School of Public Health, as well as Dr. Michael Long, who is an assistant professor in the Department of Prevention and Community Health at the Milken Institute School of Public Health at the George Washington University. So thank you both for joining, and I'll hand it off to Stephen to kick this off.
All right. Thanks, Jenny. Just a quick overview of today's plan. The goal here, the aim of the session is to introduce you to some key principles for economic evaluation of public health interventions, like, for example, those to prevent childhood obesity, and explain how the economic evaluation can support program planning and promote health equity, and illustrate these concepts with a few examples from within the Choices Project. And at the end, we'll also highlight some resources and tools that we have available. Next slide, please. And before we get too far along, we wanted to launch a little poll to learn a little bit about you and your experience with economic evaluation, whether you've worked on it before, whether you've had to assess health impacts of programs you're responsible for, whether you've had to estimate a budget for a health program, and whether you've ever had to try to combine those two things together to estimate a cost of a program per unit of health impact that program produces. So we're going to give you, hopefully you can see the poll up on your screen, and you can start to just give your answers to those three questions, and I'll pause here for just a little bit. And then I guess, Jenny, I don't see the responses. So when you see there's enough responses, you can share them. Awesome. So let's see what we've got here. So, beautiful. So most of you have been involved in trying to measure health impacts of a program, and about the same number have been involved in estimating a budget for a program. But it's interesting that very few have often tried to combine those two together, and that's kind of what economic evaluation is all about. So hopefully this will be helpful today. Thanks. Next slide. Okay, so let's make sure we're all on the same page about what economic evaluation is. It's a type of analysis that focuses on estimating the value of health programs. And it does that by considering both the health or social impacts of the program, but also simultaneously the costs or economic impacts of those programs. And the rationale for doing economic evaluations in the big picture is that resources are limited. Resources are finite. We only have so much budget, so much money, so much time, so much human resources and so forth available to deliver programs or to do things that are productive activities. And so because resources are limited and we have things we want to achieve, basically the idea is we want a way to make sure that we're getting the most bang for the buck. We've all heard that expression before. And in this context, the bang can be a health outcomes like BMI or obesity cases prevented, or other social outcomes like educational attainment or quality of life. We might also care about health equity. That can also be part of the bang. We might have a goal of reducing disparities in health outcomes. This can be tricky because the impact of the program, there can be multiple impacts and they can occur over a long time horizon. And the magnitude of the impacts of a program can be uncertain and depend on the manner of implementation or other contextual factors. Sometimes measuring the buck side of the bang for the buck can also be tricky because the cost of the program might be paid for from several different sources, and resources used to deliver the program might be shared with other programs, or there might not even be a financial transaction associated with the resource if the program uses volunteers, for example. And there could be important economic impacts of the program that occur as a consequence of the program and offset the program implementation costs. So the classic example here would be downstream cost savings in healthcare. If you prevent certain diseases, then you won't have to pay to treat them. And in contrast to more conventional program evaluation, often we want to do economic evaluation analysis before we've implemented, or at least before we've heavily scaled up a program. We want an estimate of its value at a time when we're trying to decide whether to do that program or to choose between programs or to decide whether to scale up a program or not. So we're often doing these analyses before the program is fully implemented, but they can also be done ex post after a program is already implemented to understand the value it's actually producing. In any case, a systematic approach of analysis can help us make our assumptions transparent. It can help the policy dialogue. It can allow us to do sensitivity analysis to see how different how areas of uncertainty where we might be making big assumptions, how much that matters for doing. And so that's basically the motivation. Next slide, please. And if you think about in the grand policy process, there are a lot of points and ways you can use economic evaluation. The most basic use, the way economic evaluation is usually taught, is that it's a tool to aid in decision making, to help choose the best program to implement among a range of choices given a finite budget. But we can also use economic evaluation to help us with program design, with designing an intervention in a way that will maximize its efficiency, because we can learn more about the drivers of cost and impact. And in recent years, there's been a lot more focus on accommodating health equity considerations into economic evaluation methods, so that instead of only valuing programs based on what which one produces the most aggregate health benefit for the cost. We can also consider how the benefits and costs accrue to different population groups of interest. And of course, economic evaluation can be really useful when you have stakeholders or gatekeepers who control funding purse strings that want to see credible estimates of value. They want to know, or what they might call return on investment. And so this can also help communicate value. Next slide, please. And today, of course, we're just doing an introduction to economic evaluation. And so you might wonder, well, how feasible is it to really incorporate this in your own work? And there's different levels at which you can engage with this. At the basic level, even starting today after this session, you can begin to use economic evaluation concepts in your own work, just the way of thinking about opportunity costs, thinking about trade-offs, thinking about costs and benefits, and so forth. And the next step in sort of increasing intensity would be to begin to integrate some cost analysis into planning and evaluation cycle, or to even conduct some short-term cost effectiveness studies, some basic cost effectiveness studies that might just focus on what it costs to implement the program and what the short-term outcomes are expected of the program. And those are things that, with increasing levels of skill, you could undertake. And then, the most comprehensive economic evaluation that really looks over a longer time horizon and tries to look at a lot of the complex disease processes between things like obesity and how it evolves over time and how it leads to disease and costs related to disease. Those types of things, it might be a situation where you're partnering with a modeling team like Choices to do that kind of work. Next slide, please. Okay, so also just wanted to get some terminology out here of some different types of economic evaluation. So we're using that term as an umbrella term for several methods. You can just do a cost analysis that really only focuses on measuring the costs of a program and doesn't try and compare it to health outcomes or consequences. You can do a cost effectiveness analysis, which measures costs and also measures consequences. The key thing about the consequences is it usually focuses on a single consequence and it measures it in what we'll say its natural units, like a case of obesity or a case of disease or an infection prevented, those kinds of things. Sometimes you'll hear the term cost utility analysis, which is a variation of cost effectiveness analysis that is special because it uses an outcome, a summary measure of health to measure the outcome, such as a quality adjusted life year, which you may have heard of, or a disability adjusted life year. What makes this special is that in this case, you can combine multiple different types of health effects and compare across them because you're using a common measure of health benefit like a QALY. And then lastly, some of you may have heard of cost benefit analysis or benefit cost analysis. And that's really the same thing as cost utility or cost effectiveness analysis, except that whatever the health outcomes are, they're translated into a monetary value. Sort of what is the monetary value equivalent to the health outcome? And that makes it such that everything is measured in dollars or money terms. And that's what's sort of special about cost benefit analysis. Today, we're going to really just focus on cost effectiveness analysis as the basic type of economic evaluation. Next slide, please. Yes, so let's talk about some of the key principles or concepts in economic evaluation to get to sort of form a basis. The next slide, please. So as I said before, the sort of core purpose of economic evaluation is to measure value I said bang for the buck. Is the juice worth the squeeze? There's many different ways we say this and casually, but that's what it's all about. And in order to assess value in cost effectiveness analysis, the main measure, the main thing we're trying to get to, the summary piece of information, is going to be an incremental cost effectiveness ratio. And that's a bit of jargon, but on the next slide, we'll break that down into more detail to explain what that is and how it's calculated. So one thing to mention here is that in economic evaluation, particularly in cost effectiveness analysis or benefit cost analysis, you're always comparing two programs. Now, one or two interventions or two policies. Of course, one policy can be the status quo or doing nothing, but there's always a comparator. So you always have to keep in mind when you're doing economic evaluation, there's always a comparison happening, even if that comparison is just like some intervention you care about compared to the status quo. And in this example, I'm going to call one of them program A, which we'll say is like the status quo perhaps, or some particular intervention, and then program B, which is some other intervention. And this incremental cost effectiveness ratio is basically in the numerator is measuring the difference in cost between the two programs. So you've done some work to calculate the costs of implementing the two programs, and the numerator is the difference in cost between them, and the denominator is the difference in effect of the two programs. So maybe the effect you care about is cases of obesity prevented, then this is the difference in cases of obesity or cases of obesity prevented. Next slide, please. I think we're going to go through a little bit of an example. So imagine you have two programs that you're considering. Program A has a cost of $1,000 and an expected benefit, or basically the number of obesity cases that you expect if you do program A, you expect to end up with 15 obesity cases. If you do program B, the program only costs $100, so it's less costly, but you end up with 18 obesity cases, so more obesity cases, which is not what you want. So program A costs more, but gives you more benefit. And the way we would turn that into an ICER, or incremental cost effectiveness ratio, is to measure the difference in costs, which is $900, and the difference in effect, which is 3 obesity cases. In this case, it's a -3 because we have 3 fewer obesity cases. And that's the thing that we want, is fewer obesity cases. And in this example, 900 divided by 3, it's $300 per obesity case prevented. So that's an example of the kind of ICER calculation, the incremental cost effectiveness ratio that you get from doing a cost effectiveness study. Next slide, please. Now, that ICER, that $300 per obesity case prevented, is actually not enough to answer a question about value in order to make a decision whether to implement program A or program B. Really, in this, you also need to know how much you'd be willing to pay, or how much those health outcomes that you care about are worth. And so we have a situation in our example where it costs $300, doing a particular program would cost us $300 to prevent an obesity case. And so we can only decide, we still need more information about whether that's a reasonable price to prevent an obesity case or not. Now, if we're using health outcomes like deaths or life years, there are some standard benchmarks for cost effectiveness. So less than $100,000 per quality adjusted life year is considered good value in the United States, typically, at least in the medical, when we think about medical care, medical treatments, that's a common benchmark. But when we use an outcome like obesity cases prevented, there isn't really a standard benchmark to tell us what we should be willing to pay. What is that worth to us as a society? So typically in that situation, we're using it more comparatively to compare the ICERs of different interventions that are aimed at achieving a similar outcome, like preventing obesity cases. And then we can see, well, this one costs $300 per obesity case prevented, and this other one only costs $100. So definitely, we're better off spending $100 versus $300 if, between, now it could be that we still haven't really figured out like whether a higher cost program is worthwhile or not. And that sometimes takes more of a policy discussion. Okay. But anyways, before I can move on, I didn't really explain this complicated graph we're looking at. But the idea here that I wanted to stress is that if we look at programs like the one in our example, and we put the difference in effectiveness along the horizontal axis and the difference in cost between the programs on the vertical axis, we basically end up with 4 quadrants. And in 2 of those quadrants, it's obvious what to do. If we have a situation where program A has higher costs and worse outcomes than program B, then it's obvious we should not do program A, we should do program B. That's a situation of what we call, the jargon for that is dominance. Likewise, if you have a program that costs less and provides more outcome that you care about, that's a situation where that program is dominant. It's obviously the best among the alternatives you're looking at, so you would definitely do it. But then in these 2 other quadrants, which would be, I guess, your upper right and lower left, that's where you need a willingness to pay threshold. You need to know what a unit of outcome is worth in order to figure out whether you're above the orange line or below it. So that's where it takes more work. But sometimes doing an economic evaluation helps you find out that you're actually in the green quadrant or the red quadrant, and the answer to the question becomes easy. In other cases, you have to do more work to figure out if you're below or above the threshold line. Next slide. We've already talked about incremental cost, and this is just an example to make sure you've got that idea, but you could have a nutrition intervention that changes from using white bread to whole grain bread. White bread costs $1.50, whole grain bread costs $3.50, so it's more expensive, but it's healthier, it's beneficial. What we care about in cost effectiveness analysis is just the incremental cost. So if the policy has a switch to whole grain bread, the extra cost of that is going to be $2. And that's the sort of extra cost we're paying to get whatever health benefit is associated with the switch to whole grain bread. Next slide, please. Another super important idea whenever you're doing economic evaluation, a concept that you can use right away is thinking about perspective. So whenever you're doing one of these analyses, you have to sort of take an explicit perspective, and that's going to help you decide what costs and benefits are going to be included in the analysis. And standard recommendations for economic evaluations in healthcare in the US usually recommend take a societal perspective, which means count everything, no matter who gets the benefit, no matter who pays the cost, it should be included. A narrower perspective that's often recommended is a health sector or healthcare perspective. And in that situation, you're looking at costs in the health sector, and you're looking at health benefits only. But there's also often a great interest and usefulness in looking at these interventions from different, more narrow perspectives, such as, a local Department of Health, or from the school sector, education sector perspective, or even from the perspective of individuals who might be participating in the program, or businesses who are affected by the program. Next slide, please. The next important key concept is the idea of opportunity cost. This is one where people get stuck a lot, because when you're doing an economic evaluation, what we're really interested in is the resource use that occurs, and not so much whether there's a financial transaction or not. A lot of times you'll have a situation where a resource is being used in a new program is actually a reallocation of a resource from an existing program. And so the overall budget might not be affected. And so people will often say, well, then it's zero cost. But in economic evaluation, we would say, no, there's still a cost, because a finite resource is now being consumed to deliver this program, which means it's not available to do something else with. And so it has a true opportunity cost. Next slide, please. I think we have a concrete example that comes up a lot in choices, is an issue of training. So oftentimes you might have a professional development training days that are already scheduled. It's already part of the budget. And it's really just a matter of saying, this year our training is going to be on a specific program around bullying prevention, which is going to be replaced by a training on active physical education in order to have an impact on obesity. So there may not be, it might be the same resources being used, the budget might not be affected, but we still want to estimate the monetary value of the labor and whatever other inputs go into that training, because even though those people involved would have already been involved in the training, now because they're doing the physical education training, they can't be doing some other training. And so there's a opportunity cost there. Next slide, please. So I think this is my last one. So the last key concept is, which I've alluded to already, is time horizon. And this is an area where economic evaluation can really help, especially model-based economic evaluations. There's two key time horizons or time frames that you want to think about. One is the time frame over which the intervention takes place, or the time, which could be the time over which the beneficiaries of the program are exposed to the intervention. But there's another time frame that matters, which is the time frame over which the impacts of the program accrue to the beneficiaries. So you could do a program, early in life around physical activity or nutrition, which might have an impact on excess weight. Over time, that might have an impact on the incidence of diabetes, and in the long run, that might have an impact on mortality. And you have a choice in your analysis about what kind of time frame you're going to look at. Of course, the farther out into the future you go, the more uncertain the impacts of the program might be. But it also means that you're getting a fuller picture of the potential benefits. I think at this point, I'll turn it over to Michael to pick up on applying this directly in the choices context.
Thanks, Steve. Next slide, Vinny. And I guess this is an example of thinking through what you actually do when you're dealing with an intervention that hits something like physical activity or BMI, and then you want to capture the health impact, the return on investment. If you wanted to do any of the cost utility, you would need to go out longer in the time horizon, in the analytic time horizon. And in that case, you're going to have to use some kind of decision analytic modeling to project into the future. And I think we have focused on aligning the standard intervention evaluation timeframe, where we say it costs this much to get this kind of behavior change, this kind of short-term change in BMI or even obesity, but we are also focused on modeling forward in time, and we think communicating both of those things is important to decision makers. The next slide, please. So, for example, with sugar sweetened beverage taxes, excise taxes, which I have spent a decade thinking about, I guess, or more, it seems, but it's actually very important to many stakeholders to understand what the effect of the intervention would be on the consumption of sugar sweetened beverages per day. And we have evidence on what that would do to BMI over 18 months. So we can say things with strong evidence about, well, we see changes in purchases and consumption and BMI over a short enough period that you could actually follow people, and we base it on a real trial. But that we also model over 10 years healthcare costs, cases of obesity, quality adjusted life years. And that 10-year time horizon, we chose to align in part with the Congressional Budget Office 10-year budget horizon, and a number of other agencies follow that kind of thinking. But we also have noted that the 10-year horizon does not capture the full benefit for many interventions, and does, as Steve mentioned, get uncertain as to what's going to happen, particularly when you're intervening in early childhood. But I think there's interest to model out for longer time periods, and we have been talking about that. And I know the CBO uses a 25-year time horizon for their long-term budget outlook. But with the graphic that Steve showed of the early childhood intervention and effects on mortality, that's not even close to long enough to capture the full effects that are 50, 60 years out. And you see with a lot of vaccination programs, HPV, for example, where you have a lot of advanced cervical cancer, 50 years, 60 years old with a vaccination at 10, 11, 12, you're going to have to think 50 years into the future to really understand the benefits of the program. So we have taken this, let's focus on the short term, very real, and then let's go out 10 years aligned with current thinking on projecting in policy making, and then let's still continue to talk about a longer time frame. Next slide, please. So this, and the idea that there are people who do economic evaluation, and then there are people who do programs, and they're separate, I think is a mistake in the way we think. And in our teams, many of our team members are actually much more focused on program design and epidemiology than they are on economic evaluation. But this concept I have seen from a range of partners in local government be very powerful for changing the terms of a discussion about who's doing what to impact a health behavior. And often the health department develops with their own budget interventions, provides resources to implement them, and then tries to convince somebody else to let them have access to the population, often in schools, but not always, and then have very low adoption or not sustainable adoption or very low implementation fidelity. You might see something like a diabetes prevention program in the community now with very low enrollment from the target population, low participation throughout, because perhaps we're not thinking about the people's time or the school district's time, the teacher's time to implement these things. And it's one thing to say, okay, I recognize that the schools have valuable time that they're contributing, and thank you very much, and to the participants too. But I think it's entirely different to try to make that estimation quantitative and explicit, and include these quantitative evaluations of opportunity costs of partners in planning discussions, so that it can be much clearer, like this partner needs more support to make this happen. I think that is an important move in governance, is to quantify opportunity costs and be much more explicit about including them. Next slide. We at the Choices Project have become, I mean, as many people have, but we have become very focused on advancing health equity as a part of the science of what we're doing and the practice of what we're doing in our partnerships with state and local health departments. This idea of valuing everyone equally is a core part of economic evaluation, where quality adjusted life year is the same for everyone. But as Steve mentioned, it has not always been the case that the focus has been on reducing inequities as an objective of the analysis. And so that has caused us to really think deeply about what we need to do to change the science of economic evaluation as it relates to obesity prevention. And part of that is in the identification of interventions that are cost effective and promote health equity. And I think that's where we mostly are now, that there's a lot of opportunity to just say, we can actually do both. I think a second piece that is not, I don't know if it's as important, but it is very important that we use the power of economic evaluation processes to enhance procedural justice within health planning. There are a lot of people who are just left out of the process, and the history of economic evaluation is that more stakeholders are brought into decision making, and by making the terms of the process explicit, it's a fairer procedure for the selection of an allocation of resources. So I think that is a good thing about the field that balances some of its inattention to specifically considering equity in the past. Next slide. And I think one problem that researchers are running into, and a lot of us are running into, is like, well, how do you do that? How do you think about health equity? And a lot of what I've seen is that people will start to estimate equity impacts within their model and just give the data out. And so they're coming in very late in the process to consider it. But really, the economic evaluation process starts with, well, what problems are we considering and do we care about? And is obesity prevention the thing we should be focused on, or is it diabetes prevention, or what are we really talking about? And engaging a broader set of stakeholders in that problem definition is a critical way to build equity in earlier. This selection of potential solutions or alternatives is in the field of economic evaluation is very important, because the value, the incremental value, depends very much on your comparison. So there's no such thing as value in a vacuum. And so if you select the wrong set of alternatives, and ones maybe that don't focus on enhancing equity, you're not going to be painting a full picture of what could be solutions to the problem that might also impact equity. I think the perspectives, particularly including the perspectives of individuals, is something that's a major focus of the field and can have a big impact on thinking more explicitly about equity impacts. And then the data sources, the quality and the analysis. Yes, people are focused here first, but a lot of times models don't have enough information to get good estimates of different impacts across different populations. And a lot of trials are underpowered to do so. And we've been working on trying to figure out the different mechanisms by which different policies or programs could enhance equity. But there's certainly an information gap in terms of measuring differential impact or differential risk. And so I think it's incumbent on people who are building surveillance systems to think about how they can be used later on in planning and evaluation and in modeling. And then lastly is this interpretation and dissemination. I think you have to make more effort to reach the right populations, to put the results in the right frame, so that you are making an argument that I think you can advance health equity as a core goal while also achieving your efficiency or economic goals. Next slide. I won't talk about this too much, but we use both absolute and relative measures of inequity and how they can be reduced. In terms absolute, in terms of the difference in the number of cases of obesity between populations. You can measure whether that difference goes up or down. And you can also measure the ratio of obesity prevalence and whether that changes in a positive way or not. And I think the magnitude and the relative effect are both important to consider. So those should be included in some manner in all analyses. Next slide. And we have thought a lot about mechanisms, and I think what we've landed on so far is that some interventions, like WIC, you focus on a particular population and it's going to have an effect of enhancing equity because you are targeting a beneficial program to a group that is experiencing inequities. Separately, you could create an intervention that reaches everyone, but the underlying behavioral risk varies by population, and reducing that behavioral risk would differentially improve the health of populations experiencing health inequities, like a sugar sweetened beverage tax. So that's where we're seeing most of this now, and less so in the differential response to interventions and other mechanisms, but I think we're still working on this piece. Next slide. I wanted to go through just a few examples of what we've been doing, and next slide, please. And the examples are Oklahoma implemented a WIC intervention, and this is, can you use these methods to actually choose a program and then implement it? Denver implemented the STAR intervention, and here the focus was, in both of them, was on health equity, but it was an example in Denver of refining a program to improve efficiency. And then in California, the goal of the analysis, I think at the very beginning, was to say, we want to know the total impact, but we also want to see how this could affect health equity. And we want to see this in groups that are important to California's health policy. And this is a policy that has been debated a lot in the state, but hadn't had this kind of focus on health equity yet. Next slide. And this is one of my other choices, partnerships. I just think this is a wonderful story because it's not the choices team driving what happens. It's a support role, but it ended up with a really rapid change in practice that has a real public health impact, where in 2014, the governor said, well, we need to have more evidence-based decision-making and we need to focus on cost more. And health leaders in the state during that time said, well, we could focus on obesity prevention, and WIC would be a good opportunity. And through the Learning Collaborative partnership with the Choices team, they were focused, the team was focused on evidence strength within WIC changes, and then those that were feasible and cost effective. So I think they maintained the focus from their local policy environment and determined that reducing screen time had really strong evidence, and within WIC had strong evidence, and that they could actually just, with the cost effectiveness analyses, they could actually just go and do this. So, next slide. And so you saw that timeline went from 2014, and by 2017, this thing was already in the field and being now implemented statewide, and 30,000 families have received screen time counseling, and 75% of those are taking steps to reduce screen time. So this was a amenable policy environment, really great partners, and then strong evidence already existed, combined with costing that made this just very doable for everyone. And the results are not only modeled positive, but very positive in terms of the kind of reach and impact that they're having in the population. So I just think this is a great story for moving quickly with economic evaluation to practice change. Next slide. And this is a similar story where Denver Public Health, they were focused on enhancing health equity. They identified STAR intervention, clinical intervention with decision support that they thought could be implemented, and figured out a way to lower the cost to refine the implementation by replacing the expensive mailings from the trial with the text messages in a system they already had. And through the analysis done with the Choices Learning Collaborative Partnership, they were able to see, well, this is low cost, this reaches a lot of children, this would likely improve health equity, and this is something that they thought they could do. Next slide. And I think it's one thing to say this is cheap, like, yeah, we could do this, versus let's get some really good cost estimates on whether this works. And there's already a pretty good trial showing that this can have positive health effects. And when you then compare the cost estimates from this analysis with Choices to to what their budget was already, they're like, yeah, we can definitely do this. And so now there are 11 health clinics implementing it, and they're rolling out training materials quickly. And so this is another example where when you combine strong evidence of effect with rigorous costing and some modeling and think about equity, that it makes it very easy for local partners to move ahead with a program that they were interested in but didn't have necessarily full buy-in prior to doing this kind of work. Next slide. So there's not yet an excise tax on sugar sweetened beverages throughout California. It's not that story, but this is a partnership with the State Department of Public Health and the County of Santa Clara Public Health Department to evaluate a 2-cent per ounce excise tax on sugar sweetened beverages, which is, I think, moving to become more standard from the 1 cent per ounce. And then next slide. This, I think, and the focus, as I mentioned earlier, was always on painting a clear picture on what the health equity impact would be of the intervention. And I also noted that Choices focuses on both near-term changes in behavior and other health outcomes, along with modeling healthcare costs and obesity prevalence and other health outcomes, quality adjusted life years over 10 years. So this is, if you were to look at the first year after implementation, how many servings would be reduced per person by race ethnicity, which is one of the contrasts that the partners in California wanted to see. And here you see it's almost double the reduction in Black African American Californians, and not quite that much, but substantially higher in the Latino population. So we would expect, and we did model this out, that you would see a larger positive effect on health of making that change. Next slide. So that is what happened, is that we estimated that Black African-American Californians would see a 39% greater reduction in obesity prevalence than average. So if the comparison was to all of Californians, and that is the relative measure of reduction in health inequity that we talked about, and that Latino Californians would see a 33% greater reduction in obesity prevalence than average. So the core point of the analysis is this is actually going to substantially advance health equity goals in a state by reaching the whole state and having much larger positive effects. It also has large positive effects on the whole population in terms of preventing cases of obesity and childhood obesity. And then the cost impact is important. It's the return on investment outcome that Choices uses is this dollar, the healthcare dollars return per dollar invested here. So if you spend $1 implementing this tax from both business and government, that you're going to get $47 back, and then you'll get $1.8 billion in healthcare savings. The next one, very important, is because of the way people respond to price changes on these beverages, they'll actually save money. $142, I think, is the household estimate per year that can be spent on other things. So that's a piece that had been used to oppose sugar sweetened beverage excise taxes in the past, and now being very explicit that households are going to save money, it's going to enhance health equity, and it's going to have a substantial effect on the health of the population and healthcare costs for the state. Is this, I think, is a good example of the way that partnering with the Choices team can give these state and local partners a complete package that fills in a lot of gaps in the arguments that they've been making for a number of years. So I think this is probably somewhat of a template of the way moving forward, where we're trying to address a lot of arguments and make sure that we've modeled them explicitly, as opposed to focusing only on the single target of obesity and healthcare cost savings. Next slide.
Great, thank you, Michael. Thank you, Stephen. That was a great overview and intro to those key concepts around economic evaluation. So we now have a few moments to answer some questions. So if you haven't yet, feel free to share any questions in the Q&A field. And we have a couple that have come in. So I think one was just around whether we'll be sharing the slides. And so we can share around slides and this recording via our portal, which we'll share in a minute. Again, the link to that as well. And if you have any other questions, feel free to follow up with us as well. We'll share our email at the end. And then the next question is around the equity aspect around a sugary drink tax. I thought, Michael, you could speak to around whether these are really truly equitable, given that some populations experience greater food insecurity and less access to healthy foods and education.
This is a great point, and I think it speaks to the perspective, and that's what that household cost savings speaks to a little bit, is that actually this isn't just a cost on households. There can be a shift to spending on something that they with the price change prefer and maybe healthier. Could just drink water and save a lot of money. But I think it's an empirical question too. You can see what happened in Philadelphia. You see that the actual implementation of these policies enhances health equity in populations. And the question on education and access, I think about how much marketing is used to get people to drink these sugary drinks, and then also how much of it is targeted by race and ethnicity and targeted to children by race and ethnicity. So I don't think we're operating in a vacuum or arguing that policy should be put in place without pretty substantial corporate interest in the reverse objective of increasing consumption. That said, I also get the paternalistic nature of public health, and my points about trying to enhance equity by building in a broader stakeholder engagement early in the process is an important piece. That there are certainly strategies other than this that could be implemented.
Michael, do you think also, I mean, one of the things it seems, I work more directly on the methods of cost effectiveness or applying it across a wide range of health topics. And I think a lot of times the discussion as folks are trying to integrate equity into economic evaluations, a lot of times the idea or the thought is that there's going to be a trade-off between where you're going to, in order to achieve a disparity reduction, or in order to prioritize health equity as one of the outcomes you care about, you maybe have to give up some efficiency. In other words, you might have less aggregate benefit in exchange for a more equitable type outcome. But it seems like in most of the examples from choices, you've had actually the experience that efficiency and equity are sort of going in the same direction, or they're not in tension with one another, would you say?
Yeah, I was just, as you were speaking, I was thinking, well, is it going to be more or less expensive to get the population that's already pretty healthy to be excellently healthy, or to make a shift where you have a lot of room to move. But I think it's also the idea that there's ongoing harms to the inequity pieces, that it's modifiable and unfair, and therefore removing an unfair and modifiable harm is not always that expensive. It often requires a shift in power, political power, but it doesn't necessarily have the same cost issue. So I guess and we had talked a while back with the folks from Australia, ACE Prevention, about, how do you quantify political capital and incorporate that into your analyses. But I think it's probably more that some of the things that will help the most are opposed the most because they are currently benefiting a smaller set of stakeholders. But in your examples where you're trying to reach hard to reach populations, and you just have to spend more resources, then I think it's often the case that you have to pay more to remove the unfairness.
Great, thank you, Michael, and thank you, Stephen. Well, I think we're just about at time, so we're gonna just highlight a few resources and upcoming opportunities. But first, I want to thanks Stephen and Michael for joining and leading us in this introduction today. And we hope to have you guys back soon for another training. So the first tool I want to highlight that may be useful for folks with their work is our National Action Kit. And so our National Action Kit is available on our Choices website, and it allows users to explore and compare best value for money strategies to help inform decision-making related to childhood obesity prevention. And so the Choices team has projected that the national population reach, impact on health, implementation costs, and healthcare cost savings for 15 effective strategies that can be used in multiple settings. And so here's an example of a sort of comparison that you can build using this using this action kit. I'd also like to highlight several of the resources that are available in our Community of Practice portal. So on this slide, we featured several resources to help understand cost effectiveness analysis. So we have additional training videos available featuring different experts on our Choices team discussing the concepts of cost effectiveness analysis, as well as more specific research briefs and fact sheets. We also include additional resources from our Stories from the Field series, which feature examples like the ones we shared today from Oklahoma and Denver. So we invite folks to register to become a member of our online portal. It's free and easy to do, and you'll have access to these resources as well as be in the loop for some upcoming activities. So our next session will be on November 16th from 12 to 12:50. It's a coffee chat, which is a informal yet structured conversation on a relevant topic. And the November chat will be on strategies to reduce screen time. And then we'll also be hoping to have another session on another training session. So we're going to launch a quick poll here to see if folks have thoughts on any future topics that would be of interest to you for future training sessions. And again, we feel free to email us with any questions or follow-up suggestions. Where our email is at the bottom of the screen here, choicesproject@hsph.harvard.edu. And with that, I think that concludes our session, and we thank you all for joining today, and we look forward to connecting with you all on future events. And thank you again to Michael and Stephen for leading us through today's session.
Sure thing. Bye.
Great. All right. Bye, everyone. Thank you.